Hi, this is Shauna Gunaratney, and we will be talking about treatment regimens for TB. So for treatment of latent tuberculosis infection, we prefer shorter regimens, 3 to 4 months, over 6 to 9 month longer regimens. The reason for this is that there is lower toxicity observed with shorter regimens as well as higher completion rates. These shorter regimens are not for treatment of active TB disease, and these are not for people exposed to MDR-TB. Options for latent TB infection treatment include 3HP, which involves 3 months of once-weekly INH plus rifapentine, 3HR, which is 3 months of daily INH plus rifampin, 4R, which is 4 months of daily rifampin, or the longer regimens, 6H or 9H, which is 6 to 9 months of daily INH. There is new emerging evidence looking at short regimens for treatment of latent TB infection, such as 1HP, which involves daily INH and rifapentine for 1 month. So who should get monitoring on latent TB infection? We typically recommend monthly liver function tests only in the following individuals who are getting treated for latent TB infection: those who have abnormal baseline LFTs, those living with HIV, those who are older than 35 years, those who have a history of liver disease, hepatitis, or alcohol use, if they are on 2 TB drugs, or if they are pregnant up until 4 months postpartum. When we talk about treatment of active TB disease, we recommend combination therapy. And the reason for this is TB disease creates many challenges for treatment, especially cavitary disease. And you can see in this diagram here, there are many different reasons for why it's difficult to treat TB. Due to its pathogenicity and its pathogenesis in the human host, because it walls off and creates a thick cavity wall, it is difficult often for antimicrobacterial drugs to penetrate. And we want to make sure that we don't cause development of resistance, and so we use combination therapy. Treatment of drug-susceptible TB disease generally follows a pattern of an intensive phase followed by continuation phase. This intensive phase is 2 months of 4 drugs, including INH, rifampin, pyrazinamide, and ethambutol. After these 2 months are over, we drop down to the continuation phase, which is at least 4 months of 2 drugs, INH plus rifampin. For most pulmonary TB and disseminated tuberculosis in the United States, we recommend 2 months of the intensive phase with INH, rifampin, pyrazinamide, and ethambutol, followed by 4 months of the continuation phase with isoniazid and rifampin. There are some important exceptions to this 2+4 rule. In CNS TB and TB meningitis, we extend the continuation phase to 10 months. So the individual is being treated with anti-TB drugs for 12 months total. In bone and joint TB, for example, Pott's disease, we recommend extending the continuation phase for 7 to 10 months. The reason is because it is difficult to penetrate the bone and the joint with our drugs, so we recommend extending that continuation phase. If someone still has positive sputum and pulmonary disease at 2 months, then we recommend extending the continuation phase to 7 months to fully eradicate the organism. And like we mentioned before, if we are not able to use pyrazinamide, the individual needs to be treated with 9 months of therapy. In terms of treatment of drug-susceptible TB disease, we typically recommend daily regimens over intermittent regimens that are given 3 times a week, especially in the intensive phase. We do not recommend using intermittent regimens in those living with HIV or those who have cavitary disease. Monitoring on TB therapy is an important aspect of managing TB infection and TB disease. So here is a helpful table that is from guidelines, IDSA guidelines, that recommends what should be done at each monthly visit. For example, at every monthly visit, the patient's symptoms should be checked as well as their vision, like we talked about. And then in terms of laboratory testing, we mentioned when monthly labs should be checked. And then we typically recommend, at least at month 3, that if the person's being treated for pulmonary TB, that they should get sputum smears and culture, as well as at month 2, get follow-up imaging. Let's talk about interruptions in TB therapy. How do we manage interruptions? So during the intensive phase, when someone is on 4 drugs for those 2 months, a treatment interruption is defined as a lapse in duration of therapy, and 14 days is typically the cutoff. So basically, if someone has lapsed for under 14 days, we still recommend continuing the treatment and finishing all doses as long as it has occurred within the first 3 months. If someone has lapsed at least 14 days, either greater than or equal to 14 days, unfortunately, they need to restart the entire intensive phase therapy from the very beginning. What about interruptions during the continuation phase when someone is on rifampin and INH? Those people need to start over with the intensive phase and continuation phase if they have received under 80% of the doses and the lapse is greater than or equal to 3 months, if they have received under 80% of doses and the continuous lapse is greater than 2 months, or they have received under 80% of doses and the full therapy cannot be completed within 9 months of starting. What about interruptions during latent TB infection therapy? Interruption or lapse in this means missing at least 1/3 of the regimen, so not relevant to a couple missed doses. We need to restart from the beginning if someone has lapsed therapy when they are immunocompromised, if they are living with HIV, if they are on INH and have missed greater than 3 months. If they are on rifampin, they must take 120 doses within 6 months, or if they're on 3-HP, they must complete at least 11 weekly doses within 16 weeks. Let's move on to side effects to TB therapy. So we spoke about LFT abnormalities because of the hepatotoxicity and risk of hepatitis with some of the drugs used for TB, including INH and pyrazinamide. So if LFT abnormalities are seen with RIPE during the intensive phase, usually if they occur early on within 1 month of starting treatment, this is typically from either rifampin or INH, and this carries a favorable prognosis. If these LFT abnormalities are seen later in treatment, greater than 1 month, it's likely from pyrazinamide, and this portends a more poor prognosis. So we recommend stopping all drugs when the LFT abnormalities are greater than or equal to 3 times the upper limit of normal and someone has hepatitis symptoms. So they're symptomatic, meaning that they have right upper quadrant pain, jaundice, nausea, vomiting, or anorexia. If they are otherwise asymptomatic, we tolerate an ALT of up to 5 times the upper limit of normal. If the ALT is greater than or equal to 5 times the upper limit of normal and they're asymptomatic, then we stop therapy. We also recommend watching for elevated bilirubins or alk-Phos from rifampin, and we stop if the lab values are greater than 3 times the upper limit of normal and someone is symptomatic, or greater than 5 times the upper limit of normal and they're asymptomatic. We then wait for the liver function test to go down, and then we restart therapy, typically when the ALT is under 2 times the upper limit of normal. We then start individually each drug in order of what is least hepatotoxic and most important, and in a stepwise fashion, so we can see how the liver function tests respond. And we start these medications in a stepwise fashion every 5 to 7 days. So first we start with rifampin and ethambutol because ethambutol is not likely to cause hepatotoxicity. If the person is tolerating it, then in 5 to 7 days we add on isoniazid. If the person is tolerating that, then we add on finally pyrazinamide. If the liver function tests end up rising with pyrazinamide, then we stop the pyrazinamide and continue rifampin, isoniazid, and ethambutol, just the 3 drugs for 9 months total. If someone has severe TB, for example, CNS TB, and they cannot tolerate being off therapy, then we have to treat with an entirely new regimen with new drugs, including a fluoroquinolone, aminoglycoside, and linezolid and bedaquiline while off RIPE. In treatment for latent TB infection, we recommend stopping therapy if the ALT or bilirubin is greater than or equal to 3 times the upper limit of normal and someone has hepatitis symptoms, or if it's greater than or equal to 5 times the upper limit of normal and they're asymptomatic. We then typically re-challenge when, again, the ALT or bilirubin drops to below 2 times the upper limit of normal. If someone has an adverse reaction to rifampin, then they can either retry rifampin, try rifabutin, or isoniazid. If someone has an adverse reaction to isoniazid, they can retry isoniazid later or switch to rifampin. And if someone has an adverse reaction to isoniazid and rifapentine, then they can retry rifampin. Rash can sometimes be seen, and our management depends on the severity of rash. If someone has pruritus, but luckily no mucosal involvement or fever, then we just manage symptomatically. We give them antihistamines and we continue therapy. However, if someone has a generalized rash, we stop all drugs. If they develop petechiae, we stop we check a CBC, and if there's thrombocytopenia, we stop the rifampin because that's the most likely culprit. If there's any concern for DRESS or SJS with fever or mucosal involvement, then we need to stop all drugs. We restart therapy if the rash has improved and it's not concern for DRESS or SJS, and then we start the drugs individually and stepwise every 2 to 3 days. Typically, this is in a controlled environment. Rifampin followed by isoniazid, then ethambutol, then pyrazinamide. Again, if you're running to the same issue as you were with LFT abnormalities and someone has severe TB, for example, CNS TB, and cannot be off therapy for any period of time, then again, we give them a new regimen, including fluoroquinolone, aminoglycoside, and linezolid and bedaquiline while off RIPE. We mentioned drug-drug interactions because the rifamycins are potent inducers of the CYP pathway. And so typically we see the effect on metabolism about 1 week after starting a rifamycin. And importantly, this effect will continue 1 to 2 weeks after stopping rifamycins. Typically, rifampin is the most potent CYP inducer, followed by rifapentine, followed by rifabutin. If rifampin is contraindicated, sometimes we can use rifabutin. For example, rifampin is contraindicated with cyclosporine, but can be used with rifabutin. Again, common medications to watch for drug-drug interactions include warfarin, DOACs, steroids, oral contraceptives, and others listed here. There has been emerging evidence showing that shorter TB regimens can be effective for treatment, and these have been incorporated in recent guideline updates. So there is a new 4-month treatment regimen with a clinical trial that was published in 2021 that showed that this was safe and effective. So this was a phase 3 randomized control trial enrolling adults with pulmonary TB. So there were 3 arms: a control arm with the control regimen of 2 months of RIPE followed by 4 months of INH and rifampin. There was a 4-month rifapentine arm. Those individuals were treated with 2 months of INH plus pyrazinamide plus ethambutol plus rifapentine, followed by 9 weeks of INH plus rifapentine. And then there was a 4-month rifapentine moxifloxacin arm. Those individuals received 2 months of INH plus pyrazinamide plus rifapentine plus moxifloxacin, then followed by 9 weeks of INH plus moxifloxacin plus rifapentine. The study population enrolled individuals worldwide in high prevalent TB countries, including South Africa, India, China, Haiti, Brazil, Thailand, and also in the United States. 8% of the individuals enrolled had HIV. Most of the individuals with pulmonary TB in this study had cavitary disease. 73% had cavitation, and 40% had cavities that measured at least 4 centimeters or larger. 27% of the individuals had a high burden of infection. They had 3+ AFB positivity on their smear. Individuals who were enrolled had to have drug-susceptible TB. Their isolates had to be susceptible to INH, rifampin, and fluoroquinolones. So you can see here when we are looking at the absence of tuberculosis disease-free survival at 12 months, in looking at the rifapentine and moxifloxacin arm, it appears similar to the control arm. And here, this is showing the same thing where you can see that there's not much of a difference between the rifapentine and moxifloxacin and the control arm. However, the rifapentine arm appears to trend towards worse outcomes. So the ultimate takeaways are that the 4-month regimen with rifapentine and moxifloxacin is not inferior to 6-month therapy. The other 4-month rifapentine only arm was not inferior, so should not be used. The CDC then updated their guidelines in 2022 for consideration of this 4-month regimen. This can be considered to be used in persons living with HIV if their CD4 count is over 100 and they are starting antiretroviral therapy. However, this 4-month regimen should not be recommended for the following: extrapulmonary TB, as those patients were not enrolled in this study; pediatric patients; pregnancy or breastfeeding; prolonged QTC; body weight under 40 kilograms; and resistant TB. So you can see here the joint TB guidelines were updated in 2025, showing that the 4-month rifapentine moxifloxacin containing regimen is an acceptable treatment option for those with pulmonary TB.